Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist here at the University of Colorado. And today we're talking about consolidative surgeries for folks who have metastatic cancer. And joining me is Samantha Murrell, and in person, Dr. Allie Mungo, a surgeon herself, competing with me, a medical oncologist. I make sure I have the door behind me and not in front of me. But we'll be talking about doing these surgeries for folks who have metastatic disease. And maybe you can both start by giving us a little bit of information about yourselves. Samantha, we'll start with you.
Hey everyone, Samantha Murrell. I have stage 4 lung cancer with a HER2 mutation. I had surgery 2 weeks ago, so I might be coughing a little bit, but I'm very happy to be here and talk about this important topic.
Yeah, huge to have you on.
Welcome, and awesome to have you 2 weeks post-surgery. That is great. My name is Allie Mungo. I'm one of the thoracic surgeons here at the University of Colorado. And one of my specific interests and focus is lung cancer, both in the stage 4 setting and in the primary lung non-stage 4 setting. So I'm happy to be here and lend some of my thoughts.
Yeah, I think it'll be a lot of thoughts. And then we're thrilled that you could be here in person. We work together, we're in tumor boards together. And I was like, why don't we talk about what we're actually doing here? And Samantha, you just had the surgery, so can't think of a better time, better group of people. Talk about this pretty controversial topic. Not everyone agrees that these are good ideas to do, and we don't have a ton of data guiding us as to what the right call is in any given situation. So I think this conversation is going to be really helpful. Kicking us off, Samantha, you had the call to do the surgery, and you did it 2 weeks ago. I've known you for a while, and we've been talking about whether to do this or not. Mm-hmm. So I'm curious, what were the factors that informed your decision to do a surgery with metastatic disease in the first place?
So I've been seeing a lot of webinars of specific doctors throughout the country talking about it. So I was pretty well informed on surgeons doing it on particular individuals with specific mutations in the stage 4 setting, if they had a really good response to treatment. There was no mention ever of the mutation that I have, which is HER2. We're just super, super rare individuals. So it's hard to get a group of us together and explore the data as much. But I was pretty adamant that, given my age and how otherwise fit and healthy I am, apart from having stage 4 lung cancer, is that I really thought my body could handle this surgery if I became a candidate for it. And I knew that the only way for me to become a candidate for it was to have a remarkable response to treatment. My first line treatment, which was traditional chemo and immunotherapy, I never got a complete response or an incredible response. I just got, some stability for quite some time, which is great in the stage 4 setting. But it took my second treatment, which was a targeted treatment for my HER2 mutation, to give me the results that I needed to even have the discussion about having surgery. And what initiated me kind of looking into surgery was, okay, I need to have a really good PET scan. So I pushed to get a PET scan. I think it was around 8 months into my treatment. And the PET scan revealed a remarkable response to treatment, no active uptake anywhere except for my primary tumor, which is what led me to hunt down surgeons who might take on my case. And it happened to be that my local surgeons, after reviewing my PET scan, thought that why not, let's give it a shot.
And you say hunt down surgeons who would consider your case. Did you talk to other surgeons who were not going to do it, who are not interested?
I've spoken to many different oncologists who weren't really on board. Even my oncologist now, who I absolutely adore, he's a researcher by trade. He even had to have some persuasion done by me. Not that I had to have his buy-in, but I wanted him on board with this endeavor. And I definitely had to persuade him. I went into the research of how great it would be to have all this tissue to test and look at, and that kind of persuaded him, which I found kind of funny. I knew what angle to hit to get him on board, but I've had many oncologists who have just said, "There's no point. The cat's out the bag. It doesn't matter anymore. Morally, like, we're not sure that it's worth it in you going through this." But I just persisted and found the right individuals to talk to.
Yeah. And, something you had said where you were looking for your CAT scan results and you're trying to find the best possible result where you can be a candidate for these surgeries. So I'm curious if you could speak a little bit to why is surgery the goal? We also have radiation, we have other systemic therapies, but I think there's this perception that I just need to get to surgery, cut the rest out, and there's some real strong drive to get that done.
So mine is kind of very individual case where I definitely wanted to weigh up radiation versus surgery. But my primary tumor was not a candidate for radiation, given that it was in a collapsed lung, a bunch of fluid, and it was hiding. My lung was very much a train wreck. And so the radiation oncologist said there was no way that they could pinpoint it accurately enough without damaging surrounding good tissue. So surgery really was the only option for me when weighing up those two things. I very much think that people should weigh up those two things and see what is best for them. For me, it was surgery or nothing. And I very much wanted, seeing as there was some uptake on the PET scan, I knew I wanted to obliterate it in some capacity. And it was like, okay, well, the only way I can do that is by surgery for my specific case.
I think that makes total sense. And what you're talking about, you had these PET scans for quite some time that were showing some amount of residual disease, and then the feeling of helplessness that you've articulated to me, where it's like, okay, I know it's there. We're trying these other therapies. It's not going away. Like, let's just get it out.
Yeah.
So Allie, I'm curious to hear from you, from your perspective as a surgeon, what are some of the factors that go into determining if someone's a candidate for these surgeries when they have metastatic disease and when they're not a candidate?
Yeah, absolutely. And, I think that the public opinion and the opinion of many surgeons has changed rapidly over the past 5 years about who is actually a candidate for surgical resection. So what I mean by that is, in somebody like you who presented stage 4, who has received systemic therapy and also, in your case, targeted therapy, that's working all over your body. And after you've received a substantial course of systemic therapy, is there one spot or two actionable spots that still appear to be metabolically active or still active cancer? And it sounds like in you, that was just your primary tumor in your lung. Mm-hmm. So in somebody who has limited amounts of active cancer, that is somebody who I think is a surgical candidate from a disease perspective for local consolidative therapy with surgery. Now, there are some additional factors that play into that decision. And one of those things is, what type of surgery can I do to totally remove all of the active disease that I see on a PET scan? So in your case, it sounds like it was a lobectomy. Mm-hmm. And I think that patients who can have a lobectomy, maybe even a sublobar resection, those are the people who I think likely benefit from essentially cytoreductive surgery in the setting of a metastatic lung cancer.
And when you're talking about lobectomy, different forms of surgery, is the general principle like we want to remove the least amount of good tissue while getting the tumor?
Right.
And if we have to remove too much good tissue, it may not be worth it?
Right. So in somebody who's young and healthy, we think about lung surgery in terms of smaller lung surgery to the biggest lung surgery. The smallest lung surgery is called a wedge resection, where you take out a nodule with a surrounding section of normal lung around it. The next size up is called a segmentectomy, where you take an anatomic piece of the pie of a lobe, but it's not taking out a full lobe of the lung. By the way, on the right side, you have 3 lobes, and on the left side, you have 2 lobes. From side to side, they do about half and half of the work. The right side does slightly more than the left, but anyway. So then the step up from a segmentectomy would be a lobectomy. And then the biggest lung surgery that you can do to remove tissue is called a pneumonectomy, where you remove the entire lung on one side. And I would say most of the time, it probably wouldn't be worth it to do a pneumonectomy in somebody for stage 4 disease, but it would have to be a very individualized kind of discussion, which it is for every stage 4 patient.
Mm-hmm.
Yeah, and I'm sure this principle is probably true in other areas too. You know, people have residual disease in the liver and wherever.
Totally.
And you have to determine with the surgeons, does this make sense to go after it? Because at least our perception now is that these surgeries should be really helpful, but we don't believe them to be curative in this setting.
I think that we think of them as something that can really significantly extend somebody's disease-free interval. And that's why we offer them to patients. And just like you said, it's totally true in multiple other types of cancers. I think about colon cancer as a big example of this, and that even changed within my training. So, in the distant past, we were not operating on patients with stage 4 colon cancer. Now, patients with stage 4 colon cancer get cytoreductive surgery with HIPEC sometimes. They get liver resection sometimes. They get lung resection sometimes. And then, of course, there are colon resections as well.
And Samantha, you had this discussion with the surgeon.
Mm-hmm.
How did the discussion go? I mean, what were the risks, benefits that were relayed to you when you were determining if this was a good idea?
Given that my lung literally was a train wreck, I don't know the scientific term for it, but it was such a train wreck that they honestly weren't sure until they went in with cameras what they were going to see. You can only see so much on a CT scan, right? And so they definitely did a disclaimer of, we don't know what your lung is truly like until we put that camera in. And once we put that camera in, then we're going to make the call on whether we're going to attempt this or not. So they were very truthful and straightforward with me about that and realistic, right? But that definitely weighed heavy on me, because I was like, okay, well, am I going to go into this, be put to sleep, and then woken up and told that we couldn't do it, which would have really bummed me out, honestly. But they definitely put that on the radar to make sure I was prepared.
Well, and you had the lung primary tumor. That's where your cancer started, but it had spread. And for example, it spread to your liver.
Yep.
And you had really good disease response in the liver, but we still expect there to be some level of cancer there, although small and probably inactive.
Yep.
So we don't know if that's going to be a problem anytime soon.
Right.
But there is this knowledge that cancer has spread elsewhere. Mm-hmm. So with the knowledge, what did the surgeons say would be the benefit of the surgery to remove what's active, knowing that there's still maybe residual disease in other places?
I think the mindset was, given my PET scan, if you take out that primary, then you'll be no evidence of disease technically on a scan, from a scan setting. And the less residual disease you have in your body, the better. And I made it very clear to them that I understood that I still have residual disease everywhere. Kyle has educated me on that many times. So I didn't go into this naively. I think, unfortunately, there are quite a lot of people that presume that if they get something taken out that has that disease left, and now they have no evidence of disease, that they literally have no cancer in their body at all in stage 4. And it's like, that's really not the case. There are things creeping and circulating that I just don't know about. But I think the surgeons very much like the benefits of this make sense. And morally, they were like, it makes sense to us. They even said that morally, oftentimes at stage 4, it just doesn't make sense to them and they just can't do it from a moral standpoint, which I totally understand. But they said, given my scan and given how young and fit I was, it just made sense to them to go for it. And I believe I was the first ever stage 4 patient that they'd ever worked on.
Yeah, this is an evolving area. Allie, can you speak a little bit to how the surgeons' practices are changing over time with surgeries for residual disease in patients with metastatic cancer?
Mm-hmm. And I think that you're a perfect example, Samantha. One thing, just to bounce back to something you said earlier, also, when we resect your active disease, we get an understanding of what mutations are now driving your cancer in the post-treatment setting.
Yep.
So I think, I'm just a dumb surgeon here, but your smart medical oncologists like Kyle are all over that information as to what can we do to treat your cancer in the future in a systemic manner based on this post-treatment biopsy, in a sense, that we get from your surgical debulking specimen. So I think that that's one thing. And then as far as how I think the surgeon's point of view for surgically resecting stage 4 disease has changed over time, I think that 10 or 15 years ago for lung cancer, if you had metastatic disease, you were just put in the bucket of not a surgical candidate. And honestly, 10 or 15 years ago, the other bucket just had chemo and radiation. This was before targeted therapy and immunotherapy. So things have changed so much since then to now. In the setting of targeted therapy and immunotherapy and systemic chemotherapy, when people have this incredible response to treatment, but you just see some small volume of disease left, I think that it makes sense to go after that for both the debulking reason and for the tissue information reason. Mm-hmm. Again, it has to be a surgery that makes sense for your patient. Are they medically fit enough to have a surgery? Can you do a surgery that won't set them back in terms of their recovery? So I guess one thing we could talk about is minimally invasive surgery in the setting of stage 4 disease. And that has some mixed data in the past. And honestly, I would say that my understanding of this and data of this comes from post-neoadjuvant patients, not necessarily in the stage 4 setting, but just patients who received neoadjuvant chemotherapy and immunotherapy before heading to surgery. So in some of those patients, the surgery is trickier. And I would say that my surgical understanding of that is all of those therapies are really working on the cancer cells, many of which are in the primary tumor and in the lymph nodes surrounding the primary tumor. Those lymph nodes live right between the pulmonary arteries and the airways within your lung tissue. And so if you have a profound immune response, sometimes that area which we have to dissect in to do a lung resection gets very sticky.
I was going to bring that up.
Yeah, in the older series of post-neoadjuvant lung resections, about 20 to 30% of the surgeries had to go from minimally invasive, meaning small incisions, a camera, and long instruments, to an open surgery, where we made a bigger incision to take out whatever amount of lung we had to take out then. I think that over time, we have gotten better at doing minimally invasive surgery in the post-treatment era, and that number is less than 1 in 5 now. It's not 0, and a thoracotomy isn't the end of the world. People do very well after thoracotomies a lot, but I do think that minimally invasive surgery for stage 4 patients is a possibility, as you're showing us.
Yeah, I think it was a shock to my surgeons how sticky my tissue was. They gave me pictures after the fact, and the level of just stickiness and how everything was adhesing to everything. It said it took him, I think, 2 hours to do the robot just to unadhese my lung from the lining, given how sticky it was. And he said any stickier, he wouldn't have been able to do it. But I hadn't been on treatment for nearly 10 months, targeted treatment, plus 7 months of traditional chemo. So that's a lot of stickiness to unstick.
Yeah, and I want to follow up. So earlier, maybe a couple years ago, I think no one would do this. 5 years ago, like I don't, this conversation wouldn't have been happening, at least not in the circles that I was training in at the time. This idea of when you're metastatic, everything is lowest amount of risk, palliative-based cares, quality of life, and surgery isn't usually conducive for that because surgeries are risky. So it's only recently where the risks and benefits have probably changed such that I think these surgeries, and even me as a medical oncologist, who Samantha can attest, I was not fully sure this was a good idea. And even with some of the recent data coming out, I've been more persuaded that I think it makes sense. So I'm curious, Allie, what's been the perspective from the surgeons as to are these surgeries a good idea or not for patients who have metastatic cancer?
I think that if you're somebody who is going to have a surgery for a stage 4 cancer, you should be at a place that has a multidisciplinary conference where we really dive into the nitty-gritty about you specifically and look at your PET scan and see what targeted therapies you've had before and make sure that you have actionable disease, because it doesn't make sense to do a surgery if we're going to leave stuff in every quadrant of your body, right? But if we feel like, hey, there is this one focal thing, or sometimes there are two focal things, somebody has a single brain lesion that's able to be removed or treated with radiation, and then somebody has an area in the lung that lights up. We tend to feel that you should get some systemic therapy if you are metastatic. That probably should be upfront. And if you demonstrate stability and still active disease and you are medically fit, then surgery is an option for you. And again, I would say that we should make sure that the surgery is small enough or tolerable enough that it won't hugely compromise your lung function or your quality of life. So I think that we as the surgeons are still thinking about quality of life. We still think about it in this semi-palliative way, but we also think about it in this very therapeutic, treat you, take it out sort of way. Like, I want to see a PET scan where nothing lights up in you.
Mm-hmm. Mm-hmm.
We know that there are microscopic bad actors hanging out in there, but if we can't see them on a PET scan for a couple of years, like, what does that mean to you? That's awesome.
Yep. And I will say that, after I got my pathology back, my oncologist and my surgeon, I think they were pretty confident that it was either going to be negative or it was going to be pretty nominal. There was a lot of cancer in my lung, like a lot. I think the word innumerable came up of lesions, sub-centimeter lesions all over my lung that had just never appeared on the CT scan, given how squished and collapsed my lung was. And I think my primary tumor was 30% viable still, which isn't crazy, but it's significant, to kind of justify, like, I definitely did the right thing. It made me feel better that, okay, there was a reason why I got this out. And the pathology kind of proved that.
No, I mean, it's really interesting. When I was going through med school and residency and then later fellowship, I always knew I wanted to do oncology. So I would ask these questions. So I remember being in med school and we would give chemo to a patient and you'd see all these tumors shrink down. And the little things that are left over, I'd say, oh, we'll cut them out. And everyone's, oh, no, that's like crazy. And at the time, it probably would not have been the right decision based on the other tools we have. But it's that paradigm that we don't do surgery in stage 4 individuals or individuals with stage 4 cancers is really, really strong still at a lot of places. But I think it's because back in the day, they did try that. We did a lot of these surgeries as a field. And the challenge, Samantha, we've used the seed and soil analogy where, you can see certain weeds coming up and the weeds are like cancer. You have the primary weed that first landed and that's for you in the lung. Little seeds go out throughout the body. go in the liver, maybe they go in the bone, sometimes in the brain. And the idea is some of those seeds you can't see.
Mm-hmm.
So it doesn't make sense to try to cut every little seed out. But nowadays, the weed killer we have is pretty good.
Mm-hmm.
So I think that is one thing that kind of changes the decision making. Is earlier we didn't really have effective weed killer. So if you go there and you're tearing up the garden, you're cutting throughout the body and you're resecting every bit that comes up, if you're not doing a good job controlling everywhere else,
Mm-hmm.
then, I mean, the amount of time it's taking you to recover, you're going to progress. But I think your disease biology, Samantha, was really telling that you do have these areas that were tolerant of the medicines you were on.
Mm-hmm.
They weren't growing, or at least not
No.
dramatically. They weren't really shrinking. They were just hanging out.
Yep.
And because you had that really strong stability, it made sense to go back in there and, debulk, remove the weeds we can see, remove the cancer we can see, because the weed killer seems pretty effective. And for you, that was the tyrosine kinase inhibitor, the pill you're on,
Mm-hmm.
that specifically targets your mutation. So I think that's a difference between now and 20 years ago,
Mm-hmm.
when we just had chemo, which, it's good. It's one of the better things we have, but it's not that great long term.
Mm-hmm.
Your cancer progressed on it. Most people's cancers will eventually progress on it, and more quickly than they will for the therapy you're on now.
Mm-hmm.
So I think that's a difference, that we need to readdress the paradigms we had before. Like, I'm a little more convinced as a medical oncologist that this may make more sense.
I think another big area too is the fact that, so I was on an ADC before I had surgery, and we decided to switch to a targeted therapy that was just FDA approved.
Antibody drug conjugate, for those
Sorry. Yes.
who are new to this. It's targeted chemo.
So that I could stay on my targeted treatment and not have a massive break. I think it's important to point out that people that do have these targeted pills, I think some surgeons, correct me if I'm wrong here, like to have a little bit of a break depending on what type of targeted treatment you're on. But
Oftentimes we try and hold them for about 2 weeks.
Okay. Yeah. Which is fine. Right. But like if you're doing traditional chemo or an ADC, I think they wanted a massive break. And it was so nerve wracking to me of like, I could be off treatment for like 6 to 8 weeks potentially, which was very, very nerve wracking for me of like what on earth could happen to my body in that time. So being able to take a pill and not have that kind of massive break was a massive thing for me and made me feel a lot better. So I think that's kind of changing as well, where people are on these pills that don't need a massive break.
Agree.
Yeah. What's the amount of time you would typically hold roughly for chemo versus these TKI therapies?
For traditional chemotherapy, most of the time we try and hold about 6 weeks before, 4 to 6 weeks, something like that. And then for these TKI targeted therapies, it's oftentimes about 2 weeks.
And how long after the
Afterwards.
surgery do you restart?
Also usually 1 to 2 weeks for the TKIs.
Or what about the chemo?
Same thing on the backhand.
So you're looking at like 3 months.
A long
2
time.
months.
And that's, provided that you don't have any wound healing complications that we can see from the outside.
Right.
That might delay you further.
Yeah, that's huge. 3 months off therapy for someone on chemo, as a medical oncologist, it's a scary consideration.
It's a long time.
Yeah. So I think that's a huge difference as to why these surgeries weren't considered before. Now we're getting more comfortable with them, and it seems to make more logistic sense with the surgery. And Samantha, that was one of my biggest concerns when you were on the ADC is like, I'm worried for you to come off therapy for a while.
Yeah.
Things were working pretty well. So, I want to get a little bit into the maybe psychosocial element, because I've had a lot of patients talk to me about this where it's like, I see it on the PET scan, get it out of there. And that's even come into play determining, should I do radiation or should I do surgery? Because a lot of times we'll offer both. or at least, that they're both in consideration. And we don't always think of one as dramatically better than the other. So patients do tend to have this thing that's like, I want it out. I don't want to radiate it. I want it out. Samantha, can you speak to that a little bit?
I think it's the whole concept of getting the mothership out of your body and it not having control over you anymore. And I know that's not how it works at stage 4. But I think that's very much the mindset of this thing is the thing that started it all, potentially, if you're talking about a primary tumor. So let's get it out. Or if it's something that's residual disease that isn't your primary tumor, but it's still barking, get this thing out because it's barking and it could potentially mean that I could be on treatment longer if I get it out. So I think that's very much the mentality.
Did you feel relieved after the surgery, seeing the path report?
After seeing the path report, yes. It was very emotional to me because it was relief, but also a sense of being terrified that I had that much active cancer left that scans were not showing. But then I kept reminding myself that this awful report that I'm reading is no longer in my body. So I had to keep reminding myself of that because it was a really awful report to read.
Yeah. Well, I mean, you're recovering right now. You're a few weeks out. I want to go into some of the details about surgery stuff, but how are you doing?
I'm okay. As I'm trying not to cough. I'm okay. I'm a big active hiker. I also live at 7,000 feet, which I think living at altitude, even if you're adapted, this is kind of a rough recovery living at that altitude. Because even people who have all their lungs and don't have the surgery struggle to go up the stairs. But I'm doing okay. I'm working up to more and more hiking each day. I'm up to 2.5 miles, should be up to 3 by the end of this weekend. I'm still in quite a bit of pain at nighttime. It definitely breaks through at night because that's just always the way it goes. And I get these lovely nerve sparks that are just so random. And I just feel like someone's randomly electrocuting me, which is always fun.
We haven't figured out a way, even with minimally invasive surgery, to make that 100% better. And I will say, I know there are listeners who are more familiar with non-thoracic malignancies, but when we operate in the chest, even when we make the tiny incisions, we have to go between the ribs, and there are nerves that run underneath every single rib. So whether you have the tiny incisions or the bigger incision, we always do try kind of not hurt things, but we always bugger up those intercostal nerves. And what you're describing is pretty common.
Yeah,
after
and I was told
surgery.
I have really small spaces between my ribs, which also doesn't help the situation. But otherwise, I'm doing okay. I think it's just the emotional turmoil of not being tip-top shape, but also the emotional turmoil of this being a reminder that I actually do have stage 4 cancer. I think there's a big, there's an easy way to forget that you have cancer when you're on these targeted treatments sometimes, especially when you're responding and doing so well. So this has kind of been a slap in the face of like, oh, wow, I really do have metastatic cancer that's really bad. So it's been a roller coaster, honestly, but really glad I did it. And I know that every day will get better. I just need to be patient, which is not in my vocabulary.
When you were telling me, oh, it's going to be a slow recovery, I'm like, I don't think you're capable of a slow recovery.
No,
I think it's going to be a quick recovery. And you've been hiking and doing all the things. And so, yeah, I'm interested. You told me about your perspective and the relief you feel, the anxiety around the path report. How has your community reacted to you getting this surgery?
Everyone's been super excited for me. Whether people have lung cancer or not, who have responded to me. Lots of excitement around it. I think people that have stage 4 lung cancer and have responded are even more motivated to try and explore this for them seeing as they've seen me go through it. It's a big education piece on my behalf that I'm trying to take on to make sure these people don't think that surgery is always the answer and that everyone is always a candidate, which I'd love to talk about a little bit, because I think there's a big misconception out there that no matter what your disease or where your tumor is, surgery is the answer. And I don't necessarily think that's the case, but a lot of support for sure, which has been amazing. But a lot of education has been done to get people to realize, and also to realize how big of a surgery this really is, right? It's not a little surgery. I remind myself that every day. It's not a little surgery. As I look at the picture of my lung that I have hanging on my wall now, that this wasn't a small undertaking, and that if you're not in tip-top shape, you really shouldn't be contemplating this at all in the stage 4 setting. It's not going to provide you the benefit, I don't think, that people are craving for, right? So it's so individualistic.
Yeah, I'm happy you hit on that, because I think one of the reasons people really, really push to get this, it's, I think, appropriately anxiety driven. You want to do all the things you can do.
Yep.
And when we say it's not a good idea, it's a real hit. It's a real hit to people. And it's hard for us as providers to do that, because we feel all the anxiety around that decision. But speaking to your, or following up, I guess, on what you were mentioning, you said it's a big surgery. For your surgery, did they do part of a lobe, a full lobe, the full lung? How much did they do?
They did a lobectomy. So my lower left lobe was fully removed.
Okay.
And a bunch of lymph nodes.
Right. What did they say would be the consequence of that?
Well, again, mine was a very individual circumstance because my lung was already collapsed and a train wreck. My pulmonary function was very, very nominal in that lung. So they didn't actually think my breathing would be impacted that much. In fact, they thought it might actually get better because I had so much pleural thickening, and I don't even know how to explain pleural thickening in a non-scientific manner because I don't really know what it is, but a lot of scar tissue essentially in that lung area. And so getting rid of that would provide more space for me to be able to breathe. I haven't experienced that ability to breathe better yet, but hopefully it's coming.
2 weeks is pretty soon.
Yeah.
Yeah.
I tell people after lung surgery that you won't really feel like 100% yourself until about 3 months after surgery. Then you'll not be thinking about the fact that you had surgery every day. 2 weeks is when I think the trajectory starts to go up and you start feeling better for most people.
Good.
But it's not that you ever forget on a daily basis that you had surgery 2 weeks ago yet.
Yeah.
Well, and you're mentioning the recovery, and Samantha, you were in tip-top shape, and you are. I mean, you live in Utah. You go hiking almost every day. Very active with your dog. You're doing all the things, and that made you a surgical candidate, because we talked before about the disease has to be limited. You have to be able to access it. You can't cut out too much stuff, too much healthy stuff. But Allie, who is a surgical candidate from a physiologic standpoint in how they're functioning?
So somebody who can be physically active, who can go up 2 flights of stairs without kind of missing a beat, somebody who doesn't have to wait at the landing between those 2 flights of stairs, somebody who can easily walk around the block a couple of times. Those are just the questions that I ask people before I see any pulmonary function tests. Then, of course, the actual numeric values of your pulmonary function tests allow your surgeon to understand what will it look like for you in the after we remove some of your lung setting. And we do a pretty good job of estimating, we're going to take out this amount of lung and this is what you're going to be left with. Now, in your specific situation, I've definitely operated on patients like you before, and I'm going to put some fancy schmancy medical terms attached to your trash lung. So I think you probably had some degree of a post-obstructive pneumonia where the cancer grows really close to the airway, or at least there's just so much tissue around the airway that it gets clogged. And then there's basically not only cancer helping obstruct or clog the airway, but then all of the normal mucus within your lung gets stuck back there too. And when the lung gets clogged, it just becomes from like a nice fluffy sponge to something that's very boggy and wet and doesn't inflate. And so for you, that part of your lung wasn't doing any gas exchange like a normal lung does. And so I'm sure that your surgeon who saw you and evaluated you said, well, this isn't really going to change your pulmonary function at all in a negative way. In fact, like he said, or she said, it might even make you feel better in the long term once you acutely heal from this surgery. So I guess to answer your question, I want to see somebody who can move around, because after surgery, I'm sure your surgeon told you that you need to take deep breaths and cough. That's going to expand that lung that we've left behind so that you can have good pulmonary function afterwards. When you have a chest x-ray in the future, most doctors that look at that are not even going to know that you had a lobectomy. We'll be able to see some subtleties and maybe some little staples, and we'll be able to see it on your CT scan. But on a chest x-ray, that whole area on the side of your chest should be filled with lung. And that's because your residual lung there should expand and fill the space.
And it's amazing to think about that. It really is.
It is.
Yeah.
And, you mentioned a certain level of physical activity that people need to be able to do, because surgeries are not trivial. And I want to go into like what her surgery looked like from your perspective. But before we do that, are there age cutoffs? Like, what are the other kind of criteria that helps us decide if this is a good idea or not?
Yeah, I wouldn't say that there are exact numbers that I would give you. I'm sure that everybody wants me to say some out loud, but I would say that in younger patients, we will be more aggressive. And that's obviously true in all parts of medicine. Now, no two 60-year-olds are alike. So there are 60-year-olds that are medically unfit, who are sick, who can't walk up 2 flights of stairs. And there are 60-year-olds with metastatic cancer who are climbing mountains. Those two people are not the same. And that's really why I wouldn't put an age cutoff on this.
I think that makes total sense to me. And we feel the same way in our medical oncology stuff. We don't have an age cutoff with the things we do either. And it's also a good testament that people can get cancer. And a lot of times they feel like, I got a cancer, it's over. They don't really do the physical optimization stuff, the diet, the exercise. Quitting smoking is a big one in our field in lung cancer. And because there's always this feeling of like, why bother doing these things if I have a terminal diagnosis? But I think now, as our therapies are getting better and we get to do these more aggressive things when they make sense, my perspective is hit it hard, get your body optimized for anything we want to be able to do, because we don't know what the next therapy is going to be. We don't know if surgery is going to be an option later, but I want you ready if it is. I want you to be a candidate. And Samantha, there are patients who are your age who are not candidates for the surgery. You're young, but there are people who probably wouldn't be able to tolerate it very well.
Yeah.
I don't want to put words in your mouth, but.
Yeah, I would say that honestly, in somebody who's your age, the two things that I think about are, is this really localized to this specific area? And that's true for any of the patients, but can I get out all of the active disease? And then are you going to be able to tolerate it? Most people your age can tolerate a lobectomy, but then it really goes back to the first question of, can I get it all out safely?
Okay. Well, I think that's as good a place to cut it as any. Thank you everyone for joining. This has been Cracking Cancer, and you can like, subscribe, and visit us at crackingcancer.org for more information. Thanks for joining.
Thanks for having me.
Thank you.
Hey everyone, we hope you enjoyed the first part of this episode. We were having such a riveting discussion that we decided to break this one into 2 pieces. So stay tuned next week for part 2 of our episode with Dr. Allie Mungo and Samantha Murrell talking about surgical resections in individuals with stage 4 cancers. See you next time. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.